Our next speaker is Dr. Shira Simon, who's going to be talking on I have pressure in my head.
Hello. So the title is I have pressure in my head. And I want to thank everyone, including the audience members, for still sticking here. We're almost done. I had grant support from the Cork trial when it was ongoing. So this is a case of a 36-year-old woman who was referred by her primary care doctor for complaints of worsening headaches. She thinks she may have had them beforehand, but these felt very different. She had this constant pressure in her head. And in addition to that, she was endorsing to the primary care having transient blurring in her vision. She also noticed new ringing in her ears and was very concerned about this. On review of systems, she did have around a 5-pound weight gain, and by her BMI of 29 was considered overweight. Her family history was notable for migraines, but otherwise she had a pretty unremarkable history, besides being stressed out as management consultant. So her primary care appropriately obtained an MRI with contrast. It was a good image, actually. And the report came back saying that there was an empty cella, so there's no acute intracranial process, as they always say, except there was an empty cella, and given the clinical history, they felt there was a very high suspicion for idiopathic intracranial hypertension. And we are finding this increasingly happening by the neuroradiologists because they've learned to become aware of this. So this is an increasingly common report that we're getting. So the primary care doctor spoke to his neurologist friend and decided to do an LP on the patient. And the opening pressure was 22 centimeters of water, and the constituents were normal. I just want to turn this to the panelists right now, and how worried are you from the history and the findings so far? And what questions might you have?
This is indeed an extremely common source of consultation, and it just keeps getting worse and worse and worse because radiologists know to look for those signs, and they see it everywhere because, you know what, about 10-15% of the general population, normal general population, will have an empty cella, which has nothing to do with raised intracranial pressure in many patients. Come back to the platform session tomorrow afternoon, neuro-ophthalmology. I think the Mayo Clinic team has interesting data on this topic. So anyway, I am really not particularly concerned. What I do when I have such an MRI report, instead of doing a lumbar puncture, I do a fundoscopic examination looking for papilledema. If there is papilledema, I care a lot about the empty cella. If there is no papilledema, in a vast majority of cases, I'm done. Do not do a lumbar puncture in those patients.
Excellent. And then the opening pressure of 22 centimeters of water, are you worried, not worried?
Well, taken at face value, it's okay, but it depends on how the tap was done. So under fluoroscopy, if they held the manometer above the back of the patient, you're going to get a spuriously low reading, for instance. And there are other ways in which you can get a falsely low reading. So.
Right, and I just mentioned that because a lot of times patients will say, oh my gosh, I tried 15 times to get in there, and I don't know, and I had more pain afterwards, or I felt relief afterwards. So, you have to take it all into context. Anyway, as Valerie mentioned, this is when the ophthalmology consult was placed. I wish it had been a little bit earlier, but it was at this point that we got involved. And they were asking, essentially, is there evidence of papilledema? So the exam, 20/20 vision, extraocular motility intact, the pupils were briskly reactive, there was no APD, color vision was full. And I want to ask the panel, what do you think of these nerves?
So did somebody think this was papilledema? I guess that's my question here.
Believe it or not, yes.
Just looking at, they may be elevated, you can't tell that on this kind of a picture, but and there's a little bit of disc margin blurring, but there's nothing that is in the nerve fiber layer obscuring the vessels. There's no hyperemia, there's no additional sign of hemorrhage or exudates or anything else that might suggest true papilledema. The left eye has a suggestion of drusen there. It's a little hard to tell on this, but I certainly, looking at this fundus picture, would not go to papilledema at all.
Yep.
Yeah, I agree with you, Tony. And the circumference, particularly the left optic nerve, is a little irregular, right? Which is the kind of thing you can see with drusen as well.
Absolutely. Very astute. And then the visual fields, if anyone wants to comment.
Drusenoid.
All right, so we'll suspend disbelief just for a moment and say that this is a normal appearing patient who has worsening headaches, does have a finding of an empty cella, and I'll tell you that an empty cella does have a specificity of over 90% for IAH. So that's why the neuroradiologists are very attuned to looking for this, is because it's a highly specific finding, even though it's not necessarily the most sensitive. So this patient now has a question of whether they have IH, and let's just assume for a moment that we didn't have such astute readers over here, and this is an outside ophthalmologist, doesn't have access to other things, and they think maybe it's papilledema. So this, I'll take you to the audience response question now. So knowing that this is a very specific sign for IAH, I want to ask the audience, and if you were listening to Valerie, you already know the answer. But if you weren't, you can participate. So how often does an empty cell occur in normal patients? Very good
I
listening.
told you, some of you are not listening. Wake up.
Extremely well done. Believe it or not, it was very hard to find consistent evidence on this. I'm very happy the Mayo Clinic is reviewing it because there are such wide ranges. It's anywhere from 1% with no selection bias, that they're just looking at all comers, to in excess of like 30 or 40% in certain populations. It's like an older population, normal patients still. But this might not feel that impressive, but then you have to take it into context. How ubiquitous are headaches? So it can be a point prevalence. They say that almost 80% of the population at some point might have a headache, and they might go to the ER. If they go to the ER, there's about a 70% chance that they could get neuroimaging. So take that massive population, and now we're looking for an empty cella that can happen in up to 20%, who knows, maybe even more percent of the population. So this is actually quite a common finding. We're finding it increasingly, at least in neuro-ophthalmology, as a reason for referral. So what's our job as ophthalmologists and neuro-ophthalmologists? First of all, we have to definitively say, as Tony did, is this disc edema? This is not disc edema. You can look, there's a drusen that he even alluded to on the left side. You could do fundus autofluorescence and see that there's hyperautofluorescence of where the drusen are. You can also do an ultrasound to look if there's this hyperechoic reflection, but there are many ways to look if this is disc edema. But let's say that's still vague, because you can have disc edema with drusen. So then what do you do? And that's when the empty cella does become relevant. Like I said, it does have a very high specificity. And I just want to point out to the audience, because I do remember looking frantically for where the pituitary gland is. So just in case anyone doesn't know, I've highlighted on the left is a normal pituitary gland, on the right-hand side is the empty cella. And basically, the reason they think this happens is because of the spinal fluid from the arachnoid and subarachnoid space sort of remodels the cella and flattens the pituitary gland along the walls and floor of the cella. So that's a theory behind why this might be found with elevated intracranial pressure. But there are other radiographic signs of elevated intracranial pressure. I wanted to ask the audience how they felt about those, if there was any one in particular they feel is much more helpful than others, or how you use these, if you look for them at all.
To me, of those, the posterior globe flattening is the most suggestive of elevated intracranial pressure. The optic nerve distension, it is a sign of that, but it's very variable, and it's a little bit subjective and hard to evaluate. The venous sinus stenosis may be there, maybe not. It's still sort of evolving as to what kind of test you're going to do to establish that. We've already talked about the cella.
Exactly. So not to complicate matters further, but there is about 5% of the population that might have IIH without papilledema. So the theory is, a lot of studies are showing now that if people have 3 of the 4 of these signs, then it might be recommended to proceed to a lumbar puncture to evaluate the opening pressure with this history of headaches. It actually can be an entity, IH without papilledema, even if it's just drusen that we found. If she had more of these signs, then we might have recommended an LP, and then we really have to figure out how reliable the opening pressure was. But in our patient's case, it was not IH, she had migraines. There are other methods of evaluating for elevated intracranial pressure too, and I wanted to ask the panel how frequently they use any of these, or I assume that Randy uses deflection of Brooks membrane within one patient quite frequently, but the rest of them.
The problem with the ultrasound for optic nerve sheath diameter is a lot of patients have a very patulous optic nerve sheath, and it can be expanded without high intracranial pressure. So I haven't found it that helpful. I know there's a lot of reports in the literature about it. Spontaneous venous pulsations are really talking about the effect of intracranial pressure on venous pressure in the retinal vein. Obviously, if the intracranial pressure goes up, the venous pressure goes up in the vein, and that reduces spontaneous venous pulsations, but many people at rest with normal pressure don't have spontaneous venous pulsations. Scanning laser tomography, optic nerve height, there's a very huge range of variation in optic nerve height in normal discs, so I think you can still be in the normal range. And the whole issue about displacement of the tympanic membrane, about 20 years there was a device that was used that displaces the tympanic membrane, and you have to have a round window that's patent. And as you get over the age of 25, that closes. And so that isn't such a good test for people that are over the age of 20, 25. And then that we've talked about the optic nerve OCT deflection of Bruch's membrane. I think it's best for following patients over time when it's very equivocal whether they have optic nerve edema. I don't think it's that helpful. It is helpful if you have a baseline, and this is a good reason to get a baseline OCT on these patients, especially ones that are going to have a shunt. They come into the emergency room after a shunt, and the question is if they have a shunt failure. And sometimes that displacement is the first thing that can happen when a shunt fails before the disc reswells. So it's helpful, I think, to get baseline OCT scans in that setting.
You know, each one of these is an interesting discussion unto itself, but we're getting kind of deep in the weeds here, right?
Yeah.
And you want to step back and look at the whole patient and the history and make a good clinical judgment about whether additional evaluation is needed. One comment about the height of the optic nerve, you have to be a little careful because when it's done by the machine, it can pick up the blood vessels coming off the surface of the nerve head and gives you a spuriously high reading sometimes. You can adjust it manually, but I'd be cautious looking at that number alone. When we look at it, we tend to look more at volume as opposed to individual height, and I think that's a little better parameter to follow.
I agree.
Obviously, spontaneous venous pulsation, it can be a helpful sign, but in a small nerve that's crowded with drusen, is it less likely to be seen in a normal individual?
I'm sorry, I missed the question.
Don't know of any data on that.
Would the drusen make it less likely to see a spontaneous venous pulsation?
Oh, I don't know.
Okay, so this is just to say that there are other tools at our dispense as ophthalmologists in case that the case is a little unclear. We've also had instances where patients were diagnosed with presumed IH because of the empty sella and headaches, despite whatever their opening pressure is, and they've been started on Diamox, and then they present to our clinic for evaluation of papilledema. And again, you have to just have other proxies to look for if there were footprints of papilledema. And that is a case where perhaps a ganglion cell and RNFL analysis could be more helpful. So just as a reminder to the audience, we do have pretty clear criteria for IAH with the modified Dandy criteria. In this patient's case, while she did have transient blurring of her vision, it was not positional. So this is really transient visual obscurations. It's a splotchy vision loss with positional changes. That's more specific to IAH. She endorsed ringing in her ears, which again is different from pulse synchronous tinnitus, which is more of a whooshing sound that synchronizes with the heartbeat. And then again, headaches are just so ubiquitous. That's not the most helpful sign. They can't have localizing neurologic findings except for sixth nerve palsy, which can happen with elevated intracranial pressure. And then they'll have the normal neuroimaging with the exceptions that we've just spoken about. Opening pressure, generally up to 25 centimeters of water is considered normal. But again, we've discussed that there's a lot of variability in measurement. And then it's very important that the CSF constituents are normal. If there's an elevated protein or there's any other abnormality, you have to investigate that further. And of course, there can't be a mass or thrombus in the brain. So in summary, we do have pretty clear criteria for IIH with and without papilledema at this point, but there remain gray zones. The lumbar puncture might not always be reliable. There could be disc drusen with or without edema. Headaches are everywhere, and there are these nonspecific radiographic signs that are increasingly being picked up on. So we do play a very critical role as ophthalmologists and neuro-ophthalmologists in trying to help push the thinking on this topic and following the criteria and using the tools that we have can be very helpful. Thank you.